that substantiates this concept that cannabis can be a partial solution to a really big problem, the opioid epidemic. So let's dive in here. My conflict of interest disclosure: Integrate Health is my medical practice in Maine. I do promote the use of cannabis in that practice, so theoretically, if cannabis looks like something really useful, I could financially gain from that. I see it more of a confluence of interest. Healer, which is where healer.com comes from, this is a company that I'm a part owner of. We have free patient education on the website. We also have a paid training program that was designed for allied health professionals, but we have several nurses and clinical members that are really thrilled with it. We have really fun webinars every month, and I'm not sure if this is the right time to say it or not, but I want to make an offer for ACNA and everyone about that training program. I'll wait till the end for that. And then Zelda Therapeutics is a company based out of Australia that is doing preclinical and clinical research. I advise for them, and I like what they're doing. And the Society of Cannabis Clinicians, which is an we can call it a brother-sister organization to the ACNA that is bringing healthcare professionals together, which is so important for us to be together, not to be isolated in this emerging field. So objectives: describe the challenges associated with prescription opioids, understand the evidence base for using cannabis to treat chronic pain, and spare opioids. We are going to talk a little bit about more of an addiction setting versus a chronic pain setting, but there's much less evidence there. And describe clinical strategies for using cannabis-based medications to spare opioids. So I want to leave you all with strategies. And then I've brought several printouts of our medical cannabis opioid guide, which is a guide for patients or practitioners. You can download this free from healer.com as well, which really just walks people through how to do it if they're motivated to try to use cannabis to reduce opioids. And this is just the outline of the talk. So some important questions. Can cannabis replace and reduce opioids? Does adding cannabis make opioids safer? Does cannabis prevent opioid tolerance and dose escalation? Can cannabis treat the symptoms of opioid withdrawal? Cannabis compared to other harm reduction options? How does it size up? And how to use cannabis, just the nuts and bolts that we'll get to at the end. So just a little bit about the problem. You all know it's a very big problem. Probably you know this firsthand from your practices or from a family member or a friend who's gotten into trouble with these substances. 46 people died every day in 2016. 7,000 treated in emergency departments for using it and using opioids in a manner other than prescribed. And back in 2010, 1 in 20 people aged 12 and older used prescription painkillers non-medically that year. So there's a lot of non-medical use of these drugs going on in our population. The sales of opioids quadrupled between 1999 and 2010 based on marketing. During a roughly similar period, the death rate also quadrupled. So that's the effect of good marketing. Enough opioids were prescribed in 2010 to medicate every American adult with a standard dose of 5 milligrams hydrocodone Q4 hours for a month. So if we took all the prescription opioids that were dispensed and split them up amongst everyone, you would each have a month of 5 milligrams Q4 hours. So it's a big problem here. It's big elsewhere, but it's really big here because we are the target demographic. While we have less than 5% of the world's population living in this country, we consume 80% of the world's opioid supply. To the extent that there's places where opioids are hard to come by for good purposes, like post-surgical pain and end-of-life pain, and so forth. 50% of people who took opioids in this data set from 2014 for more than 30 days in the first year of use continue to use them for 3 years or longer. So a big risk for using them for a month or more, statistically. Now, a lot of us, when we think about the opioid problem, we think about heroin. You know, we think about people dying from heroin and dying from heroin that's contaminated with fentanyl, and people just kind of think, oh, the opioid problem is a drug abuse problem. And I would say it is not a drug abuse problem. It is a medical problem. It's a medical system problem. 80% of the people that use heroin started on pills that were written by a clinician and filled by a pharmacist. We created this problem. And when I say we, I guess I'm not talking about most of you nurses out there, but rarely do I associate myself with the rest of the doctors in the world, but I will for right now, that we made this problem. We created this problem. It was the medical system that created this problem. And why? There was this fifth vital sign. There was a lot of pressure to prescribe, to treat this. If people didn't prescribe, they were worried that maybe their licenses would be at risk, or they'd be disciplined by their medical boards. I'm not saying that doctors weren't in a tough position in the 90s and early 2000s, but we created a huge problem. And in my opinion, it's our responsibility to address this problem and not just to say, oh, it's a drug abuse problem, let's send them to addiction medicine. We have to find creative solutions because our current solutions aren't doing the trick. I mean, they're helping, but it's not enough. Thank you. And so what's the basis for using opioids to treat chronic pain? Well, as of 2015, according to a review article in the Annals of Internal Medicine, there had been no studies that evaluated the long-term use of opioids to treat chronic pain. Nothing that looked at more than a year. And so you can see what's on the slide here. And even though we didn't know back in 2015 whether this was effective as a long-term treatment or not, what we did know is that there's a lot of side effects from using these drugs. So how does a clinician do a risk-benefit analysis without any data to support long-term use? Now, since that time, there have been a couple studies. This one out of the Veterans System in Minnesota looked at people with back pain, hip, or knee pain and put them into two groups. I really like this approach for studying because it's pragmatic. So it mimics what would happen normally in the clinic. We'd start someone on acetaminophen and NSAIDs, and this is the non-opioid group. And if that's not enough, maybe go up to some tricyclics and neuroleptics and so forth, and then maybe tramadol, which was not in the opioid group in this study. But you can see what the opioid group looks like. That's how it always goes, right? We'll give you some short-acting oxycodone. You come back after a couple times, that's not working. Now we're going to give you long-acting, and when that's not working anymore, fentanyl patch. So what happened in this study? No significant differences between the two groups in pain-related function over 12 months, but the intensity was better in the non-opioid group. So no real difference in function, which I like. That, I put that in the first bullet because to me that's the primary outcome is function. But the pain intensity was less in the non-opioid group because long-term use of opioids tends to increase pain. It causes a hypersensitivity to pain, probably via downregulation of that whole endogenous opioid system. Adverse medication-related symptoms were significantly more common in the opioid group, which is not a surprise. There's another study. I'm going to skip that other study. I had to cut my slides down a little bit, just an hour. But there was one other one recently that did evaluate long-term opioid use for chronic pain and had similar findings. So what do we know about cannabis in chronic pain? Is there any evidence to suggest that cannabis is an effective treatment? And since we don't have that much evidence to support opioids, yes, there's quite a bit. This is a review article from 2015 that looked at 11 randomized controlled trials. This is not just observational data. This is the gold standard, excellent quality trials. 7 out of the 11 found that cannabis was helpful for chronic pain compared to the control, whether it was placebo or another treatment. The side effects were mild and well tolerated. When you combine that with a previous review, you've got 22 out of 29 randomized controlled trials showing that cannabis is effective for pain. The evidence base for using cannabis to treat chronic pain is much better than the evidence base for using opioids to treat chronic pain. That's my point. And the National Academies of Science report agreed with this in 2017. Basically, they stated there is conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults. So that was their highest quality level of evidence, and you can see some of the other conditions. But I wanted to include sleep because, in my opinion, part of treating chronic pain is helping a patient achieve restorative sleep. It's nearly impossible to get someone better without that, so that's another major factor there. And moving on, let's talk about these two plants. And I want to just pause for a moment to look on the right. What a beautiful photograph. Now, the opium poppy is a healing plant that was provided by Mother Earth that has great properties and is actually quite safe until humans get their hands on it. Most humans. But I think for a long time people used this plant in a way that was not even a fraction as dangerous as what we're seeing out here today. We could keep our minds open about continuing to use opioid agonists in our pharmacologic arsenal, but maybe they don't have to be so strong, maybe they don't have to be synthetic, and as we make this movement toward herbal medicine and understanding how a whole plant can be safer and more effective and interact with our physiology in a more complex way that honors all these redundant pathways and just the system's complexity of our physiology, maybe we might go back there as well. But these are two beautiful plants that actually work quite well together in the body. So what do we know from animal research? And we've known this for quite a long time. If you look at the date of this review article, opioid and cannabinoid receptors are both present in pain signaling areas of the brain and the spinal cord. These signaling pathways interact with each other. It's not like we've got an opioid system and a cannabinoid system. They are working together even without using any of those plants. Just with our endogenous compounds, they seem to be working together. But when you administer cannabinoids with opioids, in animal studies, you tend to see a greater than additive anti-nociceptive effect, meaning it's not just some pain relief here, some pain relief here, we're putting them together. It's a synergistic effect, potentiating each other, or at least the THC is potentiating the opioids. So 13 years later, another review article looked at 19 preclinical studies and found that 17 of them showed that there were these synergistic effects. In summary, the average, if you look at the effective dose of morphine administered with THC versus without THC, when you give it with THC, it's 3.6 times lower. And the effective dose of codeine was 9.5 times lower when administered with THC. Imagine if we could get a fraction of this potentiation in our opioid-using patients. What if we could get 10% of that? It would still be significant. So can cannabis be used to replace opioids in chronic pain patients? Does that preclinical literature translate at all? Well, let's take a look. A 2016 observational study, so this is not randomized double-blind, this is open label, 73 chronic pain patients on opioids at baseline. Essentially, just given 20 grams of cannabis monthly, they could choose if they wanted to smoke it, eat it as cookies, get it as olive oil, some combination. They were told to take the lowest effective dose and cut down on your other drugs if you can. It was, very loose the way this was done in Israel at the time. And they were given some titration instructions. What happened at the end of 7 months? 44% of those on opioids were off. Like, you don't see that anywhere else. It doesn't show up, not even a fraction of that anywhere else. And is that the only study? Was that a fluke? No, this happens again and again. A survey of patients in Michigan, 64% decrease in opioid use amongst chronic pain patients. This is data from my practice that we collected in 2016. 542 patients that were on opioids that added cannabis to their treatment. 39% stopped completely at the time of the survey. 3/4 had been off the opioids for a year. Another 39% reduced their dose. And most of them report improvement in function and quality of life, which again is the real outcome. A lot of this talk I'm focusing on replacing opioids, but what's really important to me is how is my patient doing? Are they functioning, and what's their quality of life? And I'll use whatever tools I can use to help achieve that. Here's another study from New Mexico, a small study using a cohort of people in the medical cannabis program that were also on opioids versus some controls that were not using cannabis. This is a nice one because it went out to 17 or 18 months. In the blue bar, you can see the average morphine equivalent dose from the cannabis group, which went down and down and down on average over 17 months. And in the orange bar, you can see the non-cannabis group. Of course, there tends to be dose escalation over 17 months. when people with chronic pain are treated with opioids. So small study, but nice that we have that comparison. And I mean, that's, I'm sure what a lot of you are seeing in your practices with opioid using patients. Sometimes it's this miracle I got off them, but a lot of times they're just able to taper. More evidence that people are using cannabis to substitute not only opioids, but also benzodiazepines, antidepressants, and other medications. And so if you look at out of all the medications substituted, opioids the most, but then if you look at the group that had chronic pain, these are patients in Canada, registered in their system there. You can see quite a bit of opioid reduction. So that's about 42% of the chronic pain patients have reduced their opioid dose. You keep hearing this number, it's about the same, right? 40 and 44% in one study, 39% in my population. Here it's about 42. This is great numbers. Some data out of New England, including Maine. Green bar is they reduced their opioid a lot, or reduced the medication a lot. The orange bar is they reduced it slightly. So again, looking all the way to the left, you can see 215 people using opioids. About 40% of them reduced their opioid dose a lot. And another big chunk reduced it a little bit. And look at the other medications: anxiety, migraines, sleep, alcohol, and antidepressants. It's tempting to go into some of those other areas too, but this opioid thing is such a big problem, it deserves our focus. Looking at cannabis in the elderly, a lot of elders are using opioids for chronic pain, again, because we feel like there's not a better treatment when the acetaminophen and the NSAIDs are contraindicated or stop working. So this was 791 who responded to a questionnaire after using cannabis for 6 months, all I think over the age of 65. 18.1% of those using opioids either stopped or reduced their dose, and only 4% increased the dose or started using opioids. So probably a more challenging population to reduce or get them off opioids, but you can see that very few of them are starting opioids after using cannabis, and 18.1% of substitution of some sort is still a really nice outcome. More observational data. I'm showing you a lot here. This is really a lot of, let's look at what's happening in this naturalistic setting and publish it so people know what we're seeing. There's not a lot of randomized double-blind control studies looking at, let's actually take cannabis and use it to reduce opioids in this patient population, but the observational data is so strong, I really hope we're going to see some of these gold standard trials as well. So this is an online survey of 1,300 participants that were survey asking about how cannabis affects pain, health, and their medication use. 80% of these 1,300 people reported substituting cannabis for traditional pain medications of some sort, 53% for opioids. So if you get 1,300 people that are using, that have chronic pain, 53% substituting for opioids with cannabis. Why? Because it has fewer side effects and it works better. Why else? Well, maybe because that's fine. And so you can see here, you can see here in blue is that's the percent that stopped using. And then orange is the percent that decreased their dose a lot. So again, opioids all the way over to the left. You can see it was about 67% in this survey. And this survey had selection bias. It was collected from people that were using cannabis to treat chronic pain. And I just want to mention a little something about selection bias, which can certainly confound results, right? What some of us are seeing in the early adopters, the patients that are very motivated to get off their opioids and to use cannabis for that purpose, those results might be better than someday when we roll out a cannabis treatment to every pain clinic in the world and start really doing this with people that might not be as motivated. That those results might be different, but I think they'll still probably be good. So I have a lot of selection bias in my practice, right? People come to me because they're determined to stop taking this drug that they know is ruining their life. And I think there's enough people out there like that for all of you to get involved with them first before we start bringing this to the people that aren't quite as interested in it. So this is a quality of life change. Oh no, this is pain. So changes in pain. So blue is decreased a lot. Orange is decreased a little. So again, these are chronic pain patients that started using cannabis After 6 months later, did they have a decrease in pain that was a lot or a little bit, or did the pain stay the same? You can see almost everyone had some decrease in pain. And same with this is changes in their health, so their overall rating of health. The blue bar on the right column here, the right chart, is their health decreased a lot. How many people's health decreased a lot after they started using cannabis? How many people's health decreased a little after starting using cannabis? This should be a challenging patient population, people with chronic pain whose health might be on a trend of deterioration, but almost all of them, their health stayed the same, or it improved a little, or it improved a lot. And no real differences there amongst different genders and whether they're novice or experienced. So what does the National Institute of Drug Abuse say about all of this? They say that though none of these studies are definitive, this is straight from their website, they cumulatively suggest that medical marijuana products may have a role in reducing the use of opioids needed to control pain. More research is needed to investigate this possibility. Statement we could probably all agree with, having seen those slides that you just saw. So not bad. So what about using them together? Does this have to be we're going to take away the opioids and add the cannabis? No. Why is it safe to use them together? Well, as you all know, for every drug there's this therapeutic index, right? Kind of the ratio between the lethal dose and the effective dose. And so with alcohol, if one drink gets you buzzed, 10 drinks might be lethal for you if you take them all at once. Most of the opioids are a little bit below 10. And of course, cannabis is at the top because it's infinite, because there's no lethal dose, at least not for most people, unless you have really severe cardiovascular disease, maybe some other severe disease. Cannabis could be lethal in really rare situations, but probably not. Now, if you look at the human brain, there's CB1 receptors all over the brain, but their distribution is heterogeneous. Some areas have a lot, some areas have less. But one area that has very little cannabinoid receptors, the brainstem cardiorespiratory center. So this is the part of the brain that controls breathing and heart rate, which doesn't get influenced very much when we consume THC. This is why there's no lethal overdose of THC. That same area of the brain has opioid receptors, and too much opioid agonism can, of course, suppress breathing and heart rate. So we have this therapeutic index of opioids. Now you've seen, at least in preclinical models, that we can potentiate the analgesia, making the effective dose lower, with very unlikely potentiation of the cardiorespiratory effects. So essentially, by adding cannabis to opioids, we get a widening of the therapeutic index. The opioids become a safer drug because they're more likely to work at a dose that's further away from the lethal dose. So this is absolutely the case in animals. This is what I've observed in my practice. There's a little bit of human data that supports this, and a little bit that contradicts it as well. Oh, and then the other thing I will mention is there any potentiation of the respiratory suppression? I saw 2 abstracts at ICRS this year that have not been published that suggested adding THC to morphine could slightly potentiate the cardiorespiratory depression of the opioid. So maybe there's a little lowering of that lethal dose. Perhaps it needs to be explored more. I just don't want to say it's absolutely zero. So the other thing that's nice is when you treat animals in pain models with cannabinoids and opioids for a prolonged period of time, the animals that get that combination treatment actually get an upregulation of opioid receptors in their spinal cord and avoidance to the tolerance of the opioids with retention of the efficacy. Essentially, I mean, this is what we expect. We expect our opioid-using patients with chronic pain to come back asking for more eventually. With the ones that aren't using cannabis, it's very rare for them to not ask for more. So this was a lesson for me. When I was in residency, I remember the patient very clearly. He actually continued to follow up with me. He was on 5 milligrams of oxycodone 3 times a day, and when I looked at his chart, it was that way for almost a decade. And I was so miserable writing opioids for people in the residency clinic. I just hated it, and I hated escalating their dose. And then I see this guy who's on the same dose forever when I look at his chart, so I ask him, what are you doing? And honestly, one thought in my mind was diversion. And to answer my question, he reaches in his pocket and pulls open a container and puts it right up to my nose. So we're not discovering this. Patients have known this for a long time. The patients are teaching this to us. We have to keep listening to them. And you don't need me to drive that in because most of you are nurses, but when it's a bunch of doctors out there, reminding them to listen to patients, they're like, oh, maybe we should. And no offense to the doctors out there. So what does the CDC say about this? So I started doing this work in 2009. And I was getting people to lower their opioid doses, and they would go to the chronic pain clinic, and they would say, I'm on a lower dose, and the clinic would check their urine and abruptly discontinue their prescription. So I'm thinking, well, what are these doctors expecting? Well, they're hoping that I'm going to start writing the opioids, which I did, which was hard, but I couldn't leave patients hanging like this. And I think the other option is for the patients to go to the street, which I'm sure many of them have to do as well. So it's terribly irresponsible, and I had never seen anything like that in medicine before until I started doing these talks, and I realized by presenting at pain conferences and listening to some of the other lecturers that in that community of medicine, in that field of medicine, pain medicine, probably because it's such hard work to do without the right tools. It's really hard to meet these patients that are suffering without the right tools. It's generally accepted that you can discharge patients from your practice and just give them a list of the other providers in the area and think that that's ethically sound, which of course is the exact opposite. If you start them or take over the opioids, in my opinion, it's your job to see them through. So what is it? So then 7 years later, the CDC comes out with guidelines for opioid prescribing. What do they say about THC in the urine? They say clinicians should not test for substances for which results would not affect patient management or for which implications for patient management are unclear. For example, experts noted that there might be uncertainty about the clinical implications of a positive drug screen for THC. In other words, you don't even need to test your patients for THC because we don't know how those results would impact the treatment. That's the furthest thing from kick them out of your practice abruptly. So, and this is still happening, thank God, not in Maine, because I started writing letters as soon as this came out, letting everyone know what the current guidelines were in the fine print. But I know it's happening in other parts of the country, and you can use this as a resource. The 2017 Canadian guidelines say something similar. So, some recent data. Again, this is out of a research group in Michigan, but using a nationwide survey, these 1,300 patients, looking at adults who use cannabis to treat chronic pain. And this is looking at how they use it, which I really like because so much of the previous literature was just, are they using cannabis or are they not using cannabis? And we all know that that's a broad oversimplification, right? How are they using cannabis? That makes a big difference. So let's look at it. Let's learn from what's happening out there and the patients that are using it right now. So 3/4 are using it daily. That's interesting. Chronic pain patients, some of them don't use it daily. Something to note. Maybe we wouldn't expect that. That's not, you don't see the opioid patients taking a day off every once in a while. Not usually. 60% used it 3 or more times daily, so it seems like the most common dosing regimen is TID. And this survey didn't find many differences between novice and experienced users. So maybe that's saying that there's not a lot of change in the pattern after using cannabis for a long period of time. Now, administration routes, this is very interesting. 93.4% used 2 or more administration routes. 72% used 3 or more administration routes. And as you know, when cannabis is used via different routes, it's almost like taking different drugs. I mean, it's the same medicine, but it can affect the symptoms and affect the body in such different ways. So what is this like? Like, do we have a model for this, different delivery routes? Well, yes, mostly from pain medicine, right? If you look at standard care in pain medicine, there's the extended release opioid that's used to treat their baseline pain. There's the instant release opioid that's used to treat breakthrough pain, even though a lot of patients will just watch the clock until it's time to take their next breakthrough drug. Then there's probably a sleep aid that's non-opioid, but that's also prescribed. And then there's an anxiolytic, right? So how do we mimic that with cannabis? Well, patients are already doing it. They're using oral dosing for longer duration of action. They're using inhaled for rapid onset for breakthrough symptoms. They're using cannabis, certain varieties of cannabis that are better for sleep. They're using cannabis with strategies to manage their anxiety. So you kind of get all of this dose layering from one beautiful botanical. And then what are they choosing? A little surprise here, 70% chose varieties that were high in THC and CBD, so like these more of a balanced ratio, a type 2 plant, or low in THC and high in CBD. So only 30% were choosing the type 1 varieties that are really THC dominant. In chronic pain patients, a lot of people like some CBD in there. Female and medical-only users prefer low THC and high CBD more than their counterparts. So what about selection? This is interesting. Only 2.6% of these 1,300 respondents had any input from a medical professional. They had to figure this out. So 54.9% relied on advice from dispensary employees. So, I recognized several years ago that dispensary agents were put in a very uncomfortable position, because when a state goes medical, 95–99% of the physicians that are writing certifications just are selling certifications and say, go to the dispensary and ask them what to do. And you have someone standing there at the counter that's not trained as a clinician, that's totally over their head, doing their best to help someone that's suffering, bad situation. So that's why I developed the Healer Training Program, was specifically for dispensary agents to understand how to give sound advice, but also to recognize when the case needed to be escalated to someone with more expertise and referred out. And that program has just grown from there, but I recognize that as a major problem in the field, and it still is, and we can all do our part to take a bite out of that problem. So let's talk a little bit about addiction. Most of this lecture is about pain, but we got to talk about some strategies for treating addiction, because it's not black or white. It's not either chronic pain or substance use disorder. It's often a little bit of overlap there. And whether it's physical pain or psychological pain, people could argue that there's an affective component of pain in the chronic pain patients, meaning how are they responding to the pain, how are they processing it, interpreting it, what's it doing to their emotions and their behavior. And then same thing on the other side, on the substance use side, what kind of pain are those people really in? And so we've got some options here. We've got buprenorphine and methadone, which I'll talk about on the following slide. I think these are options that do help a lot of people and have probably prevented a lot of deaths. Then we have abstinence. That's the Nancy Reagan picture, haunting us from my childhood.
Does that work for you?
Right, so abstinence works for some people, but there's a lot of people it doesn't work for, and I think we used to just assume this was the only way to treat addiction, and clearly that's not the case. And then we have a lot of rehabilitation centers that are really well-intentioned and have good modalities and good short-term outcomes, but not very good long-term outcomes. So we're left with a need for something that works better than our current options. This is a Cochrane review from 2014 looking at buprenorphine, finding that only the highest dose, 16 milligrams or more, was more effective than placebo in suppressing illicit opioid use. Now pause there for a second, because again, I'm not sure that suppressing illicit use is the main outcome we're looking for here. We're looking for people staying alive, for people staying in treatment. I'm not saying it's a failure if they fall off the wagon, as long as they don't die and they're willing to come back. But still, this speaks a little bit to the efficacy of these drugs. The low dose and the medium dose did not suppress illicit opioid use better than the placebo, and methadone had similar efficacy, but was better at retaining people in treatment, probably because they have to go there every day to get their methadone. So better safety. So what about cannabis for harm reduction? How does it compare to some of those other options? Well, it's got a better safety profile. There's no way to die from cannabis. And even Suboxone, if it's combined with benzodiazepines, can be lethal. Safer than other opioids because of the little naloxone that's in there. There's a lower risk of dependence on cannabis than any other psychoactive substance. So this bullet point is a recognition that humans have an innate drive towards altered states of consciousness. And whether we get that from exercise or sex or singing or anything else, a lot of us end up getting it from a substance. And so you can acknowledge that there is that drive. That's probably a biological drive having to do with reproduction and survival of our species. And satisfy that with something that's safer than any other option. There's a low risk for abuse and diversion. Standardized oral preparations are even much safer than oral. So if you look at the much safer than inhaled. If you look at the nabiximols trials, based on a paper in 2015 that I co-authored, there were 30,000 patient years of data in nabiximol trials with no evidence of abuse or diversion. Actually, Dr. Russo shows the picture of there was one piece of evidence, and it came from a dog that chewed up the Sativex. And why? Because nabiximols is not a drug that people would abuse. When you absorb the cannabis via the mouth and via the GI tract, it kicks in slowly enough that even the THC that's in there, it doesn't give a strong rewarding effect unless you take a lot of it. So it's not going to trigger drug seeking and relapse and that kind of behavior. Inhaled with that rapid onset, absolutely THC does create a so-called rewarding effect. And finally, most people who stop using cannabis do so without formal treatment. Now we have some data just looking at the broad population. What happens when we pass medical marijuana laws? And it turns out that in this study, which I know most of you are familiar with, about 25% less opioid deaths in the states that passed medical marijuana laws compared to states that didn't have any laws. What I'd like to point out about this study is if you look below the red arrow, you can see some other interventions, like the prescription drug monitoring program. Every state has these now. At the time that those were being implemented, expensive programs, laws requiring or allowing pharmacists to request IDs, increased state oversight of pain management clinics. All of those interventions had no significant effect on the rate of opioid deaths. Now again, I want to say, I'm not saying that those aren't doing their job. Probably the rate going up and maybe those mitigated that acceleration of the rate of deaths or something. I do think those programs can be helpful, but in this data set is nothing compared to the power of simply implementing a medical cannabis law. Now those medical cannabis laws didn't come with the opioid guide, right? The doctors weren't telling people how to use the cannabis to substitute opioids or prevent the overdoses. This was just more cannabis available in the state, maybe more legal cannabis. I'm not even sure why there was such a drastic reduction in this data, but something happens when cannabis gets legalized. Another study showed 23% less hospitalizations related to opioid abuse and 13% less hospitalizations related to overdose. This was a 2017 study in states that had passed medical cannabis laws. Now there was a recent study that looked at a lot of this data again. Maybe some of you heard about it, and they did not find that the medical cannabis laws were associated with a change, either increase or decrease in opioid-related mortality. They said, we find it's unlikely that medical cannabis used by about 2.5% of the US population has exerted a large conflicting effect on opioid overdose mortality. A more plausible interpretation is that this association is spurious. So this was saying that previous data was probably spurious. Now, since this one came out, this was since I had prepared my slides for this talk, there's been another 1 or 2 papers that have shown, well, it actually does look like it's reducing the problems associated with opioids when we pass these laws. Now, what about CBD in the context of opioid addiction? Well, CBD is non-rewarding in any way. Unlike THC, CBD is not going to trigger those pleasure centers. It's got minimal side effects. It's so incredibly well tolerated. Minimal toxicity, even if 4.5 mice did die from super high doses of it. I don't know if you guys know what I'm talking about. There's one. Okay. There was, for those of you that don't, there was a study that looked at the toxic liver effects of high doses of CBD in mice, and it was just poorly done according to some of us. CBD reduces anxiety. It's pretty reliable for that. Anxiety is a component of relapse. It reduces the rewarding properties of opioid drugs, and it reduces their withdrawal symptoms. This has been shown in humans. It's been shown to reduce heroin-seeking behavior in animals and reduce heroin-related cue-induced cravings in heroin abusers. And I want to emphasize some of that data. So this is a more recent study published this year, a double-blind trial giving super high dose, 400 or 800 milligrams of CBD, once daily for 3 consecutive days, or just once. Once daily for 3 consecutive days. So this was giving CBD to heroin users, or previous heroin users, and then exposing them to cues that would trigger cravings. So they got a 3-minute video of either a relaxing scene in nature or something like, showing someone shooting up, okay? And so they got that video, and then they rated their cravings. And so here's some of the data, some of the results. So 1 to 2 hours after getting CBD, those that had and so the craving is on the y-axis here. Those that had the neutral cue, well, their craving didn't increase. We wouldn't expect it to in the placebo group or in the CBD group, right? That nature scenes don't increase craving for heroin. But if you look at the placebo group, the people that did get the heroin cues, their craving went way up, right? Just what you would expect to have more cravings. Those that got 400 milligrams of CBD, an hour after that cue, their craving went up, but not that much. And the 800 dose was even stronger. So 1 hour later after seeing that cue, a lot less craving with the CBD in their system. But what's really interesting about their study is how about the next day? And again, you can see reductions in their craving the following day by getting CBD the day before. Worked a whole day later, and then even more surprisingly, 7 days later. 7 days after the CBD dose, there was still a significant reduction in the cue-induced craving in these former heroin users. So that's powerful. I think CBD has a real role in that setting, especially because it's so safe. Now, what about cannabis for the treatment of substance abuse disorder related to opioids? Not a lot of data, just not a lot. This was one study from 2009 that found that intermittent cannabis users were more likely to stay in naltrexone treatment compared to cannabis non-users. Here's a study that showed that dronabinol, synthetic THC, could be used to mitigate withdrawal symptoms when people were stopping opioids and starting naltrexone. Interesting side finding of this study is that in their cohort, 100% of the cannabis users came back 4 weeks later for their second injection, while only 46% of the non-cannabis users came back. So it's looking like cannabis can support other strategies for recovery. It doesn't have to replace them. It can be used adjunctively, and it can be used in the acute withdrawal phase. Cannabis treats symptoms of opioid. If I list on the slide some of the most common symptoms of opioid withdrawal, this looks like a list of all the things cannabis is good for. Right? And that's probably physiologically not surprising because these two systems are so related. But cannabis works very well in my clinical experience for people that are acutely withdrawing from prescription opioids. And other drugs can be used as well. You can do cannabis and clonidine or cyclobenzaprine, loperamide, Phenergan, it can all work together to help people get through that really rough period if that's what they're motivated to do. And sometimes it has to be high dose. Now, this was some data out of India looking at men that were on Suboxone for opioid use disorder. And so the outcomes were the adequacy of the dose of the Suboxone, the productivity, and the quality of life. And looking at those with recent cannabis use compared to the cannabis non-users, they found that the cannabis users were on a lower dose of the Suboxone, but had equal symptoms to their non-using counterparts that were on higher doses of the Suboxone. Cannabis use didn't have any impact on illicit opioid use, and there was no difference found in productivity or quality of life. So what does this tell me? Well, it looks like it's safe for people that are in Suboxone medication-assisted therapy to add cannabis to the regimen. They might need less Suboxone. and still do well, still do just as well as the rest. So I think it's nice to know it's safe. So is it a choice? Not for everyone, but for a lot of people it becomes a choice. And I think that if we help with support, encouragement, therapeutic relationships, and real strategies on how to appropriately use cannabis, that becomes more powerful, a lot more powerful. So how to do it, this is what I think a lot of you already know, but we'll go through it. I recommend my patients take a small oral or oral mucosal dose of cannabis with every dose of opioids. I say every time that pill passes your lips, some THC should be going in there with it. It can be a little bit, doesn't have to be enough to make a person stoned or impaired, just some to potentiate that analgesia. And to always use the lowest effective dose of cannabis to avoid building tolerance. This is crucial. If they're building tolerance to THC, the THC is not going to serve them in their goal for reducing their opioids. So they need to do a sensitization first before they start reducing. Use inhaled cannabis for breakthrough symptoms. Because of that rapid onset of inhalation, you can use it for breakthrough pain, you can use it for cravings. I've had several patients tell me the story that they're watching the clock to see when they can take their next instant-release oxycodone, and they know if they go to the cabinet before it's time, they're going to be short at the end of the month, and then they're going to get in trouble with their doctor. They're going to have to go through a couple days of withdrawal before they get the prescription filled, and they can take a toke, and next time they look at the clock, it's an hour past the time they were supposed to take the dose. So this is what patients tell me. So now I want to take it further, because cannabis can be used like a pharmaceutical, but it's so much more. It's just so much more. If there's one point you leave with, let it be this one, that we can use cannabis as an adjunct to non-pharmacologic treatments. So I always encourage my patients to use cannabis to enhance health-promoting non-pharmacologic activities like savoring, exercise, meditation and prayer, journaling and reflecting, and then other cognitive and behavioral therapies. This is on my website. I've got several breathing exercises, gentle physical exercises, and meditations that I've designed for people to use in conjunction with cannabis, and that's all free. Now I highlighted savoring here because in non-cannabis related literature, there's a very quickly growing and strong evidence base that the mindfulness practice called savoring can break the cycle of opioid dependence and opioid abuse and essentially despair, because a major component of that downward cycle is anhedonia, basically the inability to experience pleasure from natural activities that would normally produce pleasure. So, and people feel so low that they end up getting to the point of taking the opioids just to feel a little bit of that pleasure, right? Because it's so hard to have that in their life, and it's really a downward spiral. They start focusing on the opioids because that's the only source of pleasure, and start ignoring other things in their life, and that destroys their relationships, and the spiral goes down and down. So to break the cycle, you can use a practice called savoring, where essentially it could be some flowers, just looking out the window, whatever it is, a nice meal. You get into that mindful state, you chew every bite thoroughly, you pay attention to the taste, and by restoring those pathways, those neurologic pathways associated with natural pleasure signals to appropriate healthy stimuli, you can get a lot of improvement. So that's Eric Garland and something called the MORE protocol. If any of you are interested in their work, it's very powerful, something I'm excited about. He hasn't thought about combining it with cannabis as far as I know, or hasn't written about it, but I think a lot of you know that cannabis can enhance natural pleasure, right? Even if we're not in a state of anhedonia, it can still make things that are safe and natural, that are pleasurable, feel even more pleasurable. So what about cannabis enhanced savoring as a way to break that cycle of opioid addiction and dependence? And then to use cannabis to promote regular sleep patterns, which should probably be number one. If you're going to try to reduce opioids, you got to get people sleeping. Select a combination of CBD and THC. It seems like both are useful from all this data. If you don't know where to start one-to-one, it's not rocket science. But many people would rather do higher levels of CBD during the day and higher levels of THC at night. Cannabis-naive patients are kind of a special case. Now, this isn't everyone, but I see some patients rapidly reducing their dose when they start the cannabis. Now, I'm wondering, am I the only one? Because I was in a group of experts developing a consensus paper around this topic in Canada recently, and others hadn't seen this. Does anyone see someone who's using opioids to treat chronic pain that's never used cannabis? Sometime in that first 2 weeks when they get their cannabis dose high enough, they start breaking their pills in half and are literally on half the dose. Can you just raise your hand if you've seen anything like that? Thank you for validating that. I'm not making it up. Maybe it's not happening in Canada. I'm not sure why this started. So yeah, a lot of people get this rapid reduction. Then it kind of plateaus and you got to continue to taper slowly. But there can be a rapid reduction there. For experienced cannabis users, make sure there's no tolerance. Do my sensitization protocol. It's 6 days. It involves 2 days of cannabis fast. That's very intentional. I walk them through it. There's little videos giving them support and worksheets to fill out. And then if they're only using inhalation, they should familiarize themselves with non-inhaled delivery methods before they start attempting to taper their opioids so they can take advantage of that dose layering. Now, I have seen some patients where kind of low and moderate doses of cannabis are not, it doesn't seem like they're potentiating the opioids. A patient's not able to taper, and in some of these cases, very high doses do work. So, you know, a lot of people are familiar with it, more of like a cancer-like protocol where you just take so much THC that you don't even feel the THC anymore, and it might be a few rough days at first. And, sometimes this works. Sometimes this strategy actually can get people off of opioids, especially when it's more in the substance abuse realm versus the chronic pain. So that's what I have up here. You can get it on the website. And then for my last 5 minutes, I just got to go a little bit deeper here. Because the opioid problem has something to teach us, has many things to teach us. And so I want to make sure that we together in the cannabis community can collectively learn from those problems and not repeat those mistakes. So here is the number one cost of healthcare, you know, in our country, maybe in our world, right? Again, we have a plant that's a sacred plant that has great healing potential, maybe not as great as cannabis, but there are absolutely spiritual and healing effects from tobacco. And what we have done to it has turned it into the number one killer. Probably, like it was said earlier today, it probably should be Schedule 1. So here again, you know, I already showed some of these images. We take, you know, fairly safe therapeutic botanical and turn it into a killer, the number one killer of people under 50 in this country. I mean, it's just crazy. And then there's this, which is a little less obvious, but very big, probably the bigger problem than any of that, okay? It's what the heck are we eating and why? What have we done to our food system? It's for profit, that's why. Same reason the opioids were marketed and quadrupled the rate of killing. And so please don't be blind to this. These are natural things that can heal our body, and we're ignoring them and changing them and turning them into pure poison that most people are eating all day, every day. We wonder why chronic disease is so prevalent. So how can we keep cannabis safe and healthy? I think as stewards of this movement in its early stages, let's start thinking about this so that we don't repeat those mistakes. So I've got some advice, and maybe some of you have ideas too. But in every jurisdiction, home cultivation and artisanal production has to be allowed. We cannot let oligopolies and monopolies take over. So thank you. You have to fight tooth and claw, and for those of you that are involved in cannabis businesses, I don't care if it hurts your bottom line or helps it, you must advocate and spend your lobbying dollars on getting home cultivation and artisanal production legalized. Otherwise, it's not legalization. And that competition is just helpful. We need to heal the harm of prohibition. How can we move forward without thinking about the past? How many people are still sitting in jail for smoking and doing How many people were providing a community service and risking their freedom to bring a medicine to people in their community, and now they're still in jail while everyone else is starting to make money off of it? It's crazy. And then we have to be ethical. So our energy and resource management, the use of pesticides and toxins, child labor, I mean, These are lessons learned from tobacco and opioids that we need to apply to cannabis before it gets out of control and in the hands of the big wheels people. We gotta keep the reins for a while. And then transparency in advertising. Let's not claim that cannabis cures everything, even though kind of it seems like it does. It doesn't for every person, right? That's the point. How many people here have seen cannabis non-responders? How many people have never seen a cannabis non-responder? Okay. So, let's not make claims that are outrageous. Let's keep it realistic and keep it conservative and retain our credibility. And then let's look to traditional cultures that have been using cannabis for a long time and see what lessons we can learn from them. Do we have to recreate this whole thing? I think there's a lot of good people to learn from out there. So what else can you do? That's what we can do as an industry, but what can you do as an individual? Vote with your dollars, support local businesses and ethical companies despite their higher costs. Their costs have to be higher. Don't shop for the lowest price point. Go with a good company. Within the cannabis industry, make sure the people you work with understand and love cannabis. They don't have to use it every day, but how many of you know people in the cannabis industry that have never tried it? I would like to get the spirit of the plant in them because then they're going to be more likely to give back once they see how beautiful it is. To grow your own cannabis. If you can, if you live in a place where it's legal to, even if you don't need it, put some plants in your backyard after the harvest, share it with your friends and with your community if it's legal to do so. Maine is a state where that's, right now, the only way adult use cannabis is legal is to get it for free from a friend or grow it for yourself. It's going to change, but that's pretty cool. Assume that cannabis cannot be used like a pharmaceutical exclusively. It's just the power is so much less if we just think about it as a drug. But if we start thinking about it as a method for improving the patterns and rhythms in someone's life, improving their relationships, we can use it for therapeutic horticulture. They get to grow and produce their own medicine. They can share it with their community. They can use it as an adjunct to meditation and prayer. There's just so many ways that we can use cannabis besides just take this pill. And then model and teach responsible use of cannabis. As legalization becomes more widespread, there's a lot of people wondering, how do I use this responsibly? And they don't need to figure it out through trial and error, right? Most people learn how to use cannabis in high school to try to get as high as they can, as fast as they can, as secretly as they can. That's not the safest, most effective way of using cannabis as a responsible adult substance. A psychoactive substance that's safer than alcohol and safer than tobacco. So those of you that do know how to use it safely and responsibly, model it. Come out of the closet in your community. And that's all. There's a discount code NURSE. Just put NURSE in if you want to sign up for the training program. We'll give you $50 off, and then for the next 3 months, we'll donate half of the rest of the revenue to the ACNA.
Wow.